Episode 10 Proximal Control Vascular Surgery Exam Prep. Non-atherosclerotic lower limb ischemia, which is also termed as young claudicants. This is high yield and rare cause of claudication. FRCS and European Board Vascular Surgery Exam Focused Teaching. Welcome back to Proximal Control. I'm your host, Momia. This is the podcast where we prepare for the vascular exams the same way we prepare as a day one consultant, with structure, judgment, and control. Because in vascular surgery, control is everything. Alright, welcome back to Proximal Control. This is one of those topics that keeps coming up in written SBS and short cases because it tests whether you can spot a pattern, not just memories PAD. And the pattern is simple. If the patient is young, athletic, has claudication, and the story doesn't fit atherosclerosis, or they have got palpable foot pulses and a normal resting ABI, but they still get classical exertional symptoms, you must think rare cause and prove it properly. Now, let's talk about the non-atherosclerotic lower limb ischemia. When we say non-atherosclerotic lower limb ischemia, we are talking about limb ischemia caused by things like extrinsic compression, developmental anatomical variants, cystic disease of the arterial wall, congenital arterial persistence, and exercise-induced intimal disease, rather than plaque. Let's now talk about the epidemiology and risk patterns. For popliteal artery entrapment syndrome, the textbook highlights the classic profile, male preponderance of about 85% and over 60% occur in athletes, and bilateral presentation is about 30%. For functional entrapment, the textbook points that it may be around a quarter of patients in some series, and it's often due to hypertrophy of the medial head of gastrocnemius, with the feet short, stocky male with big calves. For persistent sciatic artery, the high yield point is not its prevalence, it's the consequences. Aneurysm, thromboembolism, and anatomical pattern, so that can trick you clinically. The textbook includes a review dataset with 159 patients aged 59 years and 80% symptomatic. For external iliac endofibrosis, the key is that it's an athlete's problem. Classically cyclists, where resting tests can be normal and symptoms are exertional. Let's now talk about the pathophysiology. Okay, we build the mechanism cleanly because SBS often asks what's the underlying pathology. So popliteal artery entrapment is essentially repeated compression in the popliteal fossa. The textbook explains compression causes fibrotic change progressing from adventitia to intima, and the end result can be aneurysmal degeneration and/or thrombosis. The textbook also reinforces the same idea and adds the exam warning: popliteal artery entrapment syndrome is not benign. Progressive injury and even limb loss have been described. Now, cystic adventitial disease is different. This is cystic formation in the adventitia. The textbook frames it as implantation of mucin-secreting mesenchymal cells in the adventitia during development. So you get a cyst in the wall compressing the lumen from the outside in. Persistent sciatic artery is congenital persistence of the sciatic artery with variable superficial femoral development. Clinically, it can predispose to aneurysm and embolization because the vessel is not built for that long-term hemodynamic role. Textbook dataset reinforces it's often symptomatic and often presents later with complications. External iliac endofibrosis is essentially a focal intimal thickening or fibrotic narrowing related to repetitive hip flexion and high flow extension. The exam point is it behaves like exercise-induced arterial limitation, and it's frequently missed if you only do resting ABIs. Now let's talk about some relevant anatomy that actually need for the exam. Okay, here's what matters. For popliteal artery entrapment syndrome, the key anatomy is the relationship between the popliteal artery and the medial head of gastrocnemius and other structure around the popliteal fossa, and the fact that variants arise during embryological migration and limb development. The textbook explains that embryonic migration of the medial head of the gastrocnemius across the fossa alongside the development of the popliteal artery superficial to the popliteus creates the risk of variants. And you must know there are 6 variants described in the textbook. And the exam expects you to say these 6 variants very clearly. Okay, now let's talk about these 6 types, which are anatomical classification of popliteal artery entrapment. So if we talk about the type 1, the popliteal artery in type 1 takes an aberrant medial course around the normally placed medial head of gastrocnemius muscle. So you see here the gastrocnemius muscle is normal, but the artery itself take a medial course, and that's your type 1. Now what about the type 2? The medial head of gastrocnemius has more lateral insertion on the femoral condyle, and hence the popliteal artery runs medially and inferiorly. So see here the popliteal artery is running medially because the medial head of gastrocnemius has already moved towards the lateral femoral condyle. That's why the artery is on the medial side. Now the type 3, if you see here, there is abnormal muscle slips or fibrous bands, either the artery to the medial or lateral femoral condyles. So that means there should be an abnormal muscle slips or fibrous bands. That is type 3. And what about type 4? In type 4, the popliteal artery is entrapped by the popliteus muscle. Nothing to deal with the gastrocnemius, and that's type 4. And in the textbook it's mentioned that in this type 4, a persisting axial artery replaces the popliteal artery. What about type 5? In the type 5, the popliteal artery and vein are involved in any of the aforementioned subtypes. So if you see the vein is involved with the artery, then it's type 5. How I remember? Type 5, that's V and V for vein. Okay, now let's talk about type 6. Type 6 is always functional, and that's a functional variant. That is muscle hypertrophy in a normal anatomy, and this muscle hypertrophy causes functional compression of the popliteal artery and vein. No anatomical abnormality is noted there. And that's all about the 6 types, and this is really important for you to remember for the exam. Now for the cystic adventitial disease, the anatomical point is most commonly popliteal artery, but the textbook reminds you it can involve external iliac and femoral vessels too. For persistent sciatic artery, the anatomy clinical crossover is that femoral pulses may mislead you depending on the superficial femoral development, and imaging must define the whole inflow and outflow pattern. For endofibrosis, it's the external iliac artery and its relationship to hip flexion and athletic biomechanics. Now let's talk about some natural history and complications. This is where candidates are tested often because they either assume claudication only or they overtreat without appreciating progression. The popliteal artery entrapment syndrome, the natural history data are limited, but published series suggest a minority, median 14%, present with severely damaged arteries such as occlusion, stenosis with post-stenotic dilatation or aneurysm formation. In the textbook, it also flags that functional entrapment seems less prone to arterial damage based on few reports of complications. For cystic adventitial disease, the complication is progression to severe stenosis, occlusion, and then ischemia. The exam-relevant natural history point is actually about treatment durability. The textbook explicitly says outcomes are much better when you do cyst evacuation plus removal of cyst wall. compared to simple evacuation. For persistent sciatic artery, the natural history is complication-driven. Aneurysm, embolization, and limb ischemia in a cohort where most were symptomatic. For endofibrosis, natural history is persistent exertional limitation and recurrence if treated with wrong modality. Again, the big exam hook is the statement that there does not appear to be a role of certain endovascular approaches in these scenario type settings. Now let's talk about the clinical presentations. Popliteal artery entrapment syndrome. Think young athletic patient with exertional calf pain, claudication, or even CLTI in severe cases. The textbook explicitly says, suspect it in young, especially athletic, with claudication symptoms or CLTI. The textbook adds that symptoms can be atypical if there's overlap with venous or tibial nerve involvement, like anterior compartment pain, numbness, and paresthesia, and about 10% may present with acute ischemia due to thrombosis. The red flag pulses can be normal at rest, then vanish with provocation. The textbook gives the classic exam finding: reduction or obliteration of pedal pulses during active plantar flexion. This is very important to remember. So, you will get the reduction or obliteration of pedal pulses during active plantar flexion. Now let's talk about cystic adventitial disease. It's typically focal popliteal disease, often in patients without atherosclerotic risk pattern, and symptoms can mimic classic claudication. The key is suspicion plus imaging pattern. What about persistent sciatic artery? This can present with limb ischemia or aneurysm-related symptoms. The exam point here is, do not assume SFA disease if the whole arterial map is congenital variant. What about external iliac endofibrosis? Exertional symptoms in high-end athletes or cyclists. Resting vascular exam can be deceptively normal, and diagnosis is missed unless you do post-exercise testing and appropriate imaging. Okay, now let's talk about the assessment. If I'm answering in the exam, I would structure it like this. First, I confirm this is true limb ischemia and not a mimic, and then I decide whether it's atherosclerotic or not, based on phenotype and testing. Then I use targeted dynamic testing and imaging to confirm the specific rare cause, and only then I choose treatment. Because some of these conditions are harmed by inappropriate angioplasty or stenting. And the textbook gives you a simple starting move. Document peripheral pulses and resting ABIs, and if the story is convincing but pulses are palpable or ABI normal, do exercise testing and post-exercise ABIs to diagnose it. What are the differentials? When an examiner gives you a young claudicant, you need to say the differentials includes popliteal artery entrapment syndrome, cystic adventitial disease, endofibrosis, congenital variants like persistent sciatic artery, and other non-atherosclerotic arteriopathies, plus non-vascular mimics like musculoskeletal or compartment type pain. And the textbook specifically reminds you functional entrapment can overlap clinically with chronic compartment syndrome symptoms. Now let's talk about investigations, bedside, non-invasive imaging, and interpretation points. Resting ABI is not enough. In textbook, it's mentioned in convincing claudication with palpable pulses or normal ABI, the exercise testing and post-exercise ABIs should be done. Dynamic testing is the exam differentiation for popliteal artery entrapment syndrome. You have to remember the maneuver: active plantar flexion causing reduction or obliteration of pedal pulses, and duplex or arteriography using the same maneuver can show kinking or compression of the popliteal artery. The provocation test can also be applied, which is forced plantar flexion, and that has been extensively reported as reliable for diagnosis. And there's a nice high-yield point that you need to know. You may use a tibial nerve stimulator to induce gastrocnemius contraction and force plantar flexion, looking for waveform dampening distally. But intra-op assessment of complete decompression is imprecise. What about the cross-sectional imaging? CT or MR can demonstrate the anatomical abnormality in popliteal artery entrapment syndrome. So your exam line is I would start with duplex including dynamic maneuvers, then define anatomy with CTA or MRA and reserve catheter angiography if needed for planning or unclear findings. For persistent sciatic artery, the take-home is imaging must define the full arterial tree. For endofibrosis, the key is to produce symptoms and demonstrate hemodynamic limitation, often requiring exercise testing and imaging targeted to the iliac segment. Now let's talk about the management. Management is where the exam tries to bait you into wrong procedure. So I want you to remember one sentence. In rare cause, treat the mechanism, not the stenosis. Popliteal artery entrapment syndrome. Let's talk about the management of popliteal artery entrapment syndrome. First, decide if it's anatomical or functional, and whether the limb is symptomatic and or shows arterial injury. Symptomatic patient should be treated by division of the medial head of the gastrocnemius and or reconstruction of the popliteal artery, depending on the arterial lesion. Surgery may be indicated for an asymptomatic contralateral limb when anatomical entrapment is detected. And also, the functional variant should only be treated when symptomatic. Asymptomatic functional entrapment may be physiological and no data supporting surgery, while asymptomatic anatomical entrapment is controversial. But if imaging shows arterial injury, offer surgery to relieve entrapment and prevent further damage. There does not appear to be a role of angioplasty or stenting in these patients, either in acute or stable presentation. So, if the SBA gives you young athlete popliteal compression focal stenosis, the answer is decompression, not stenting. And if they present with severe acute limb ischemia, you can say thrombolysis can clear runoff, but all these patients subsequently require operative repair of the popliteal artery. Now, how would you decompress the popliteal artery entrapment syndrome? In popliteal artery entrapment syndrome, the operation is decompression plus arterial repair if damaged, using either a posterior lazy S approach for exposure of the popliteal fossa or a medial approach if a bypass is needed. The key structure to name are the popliteal artery and vein and the tibial nerve. And the typical step is division or resection of the medial head of gastrocnemius to relieve compression. If the artery is diseased, such as stenosed, occluded, or aneurysmal, then you add reconstruction or bypass, often using suitable vein conduit. And this is the safe exam answer. And you can say release the entrapment and repair the artery if it is damaged. Now let's talk about cystic adventitial disease. The management of cystic adventitial disease states that outcomes from evacuation plus removal of cystic wall are much better than simple evacuation. And that's preferred approach for isolated short segment stenosis. If there's extensive degeneration, you should resect and bypass. And it's mistake to do patch angioplasty after extensive cyst evacuation and wall removal because of significant early failure rates. Whereas bypass durability is excellent. So your exam answer is if it's a short segment and suitable, cystic excision plus evacuation with wall removal If the wall is degenerative, resection and bypass. Avoid patch after extensive cystic surgery. For cystic adventitial disease surgery, I would expose the affected artery, most often popliteal, identify the cystic segment, evacuate the cyst and remove the cyst wall when it's focal stenotic lesion. If the arterial wall is extensively damaged, I would do resection with bypass rather than patching because patch angioplasty after extensive cyst work has highly early failure rate. Now let's talk about persistent sciatic artery. For persistent sciatic artery, the exam wants your recognition and planning rather than pretending there's one universal operation. The key is confirm anatomy fully, identify aneurysm or thromboembolism, and plan treatment based on whether it's aneurysmal and how the limb is supplied. There is a retrospective dataset which tells you the condition is often symptomatic, and in that review of 159 patients, 80% were symptomatic, so you are not dealing with an incidental curiosity most of the time. So in the exam, I would say I would image from inflow to outflow, define whether SFA is hypoplastic and whether the sciatic artery is dominant, and then treat aneurysm or embolic source appropriately while preserving limb perfusion. Now let's talk about external iliac endofibrosis. This is often about an elite athlete or a keen cyclist, exertional symptoms, normal resting test, and you need the right answer. For rare cause, generally pushes you to use exercise or post-exercise hemodynamics to confirm the diagnosis before intervention. So your exam answer is confirm with exercise hemodynamics and targeted imaging, treat the underlying pathology, often surgical correction rather than endovascular treatment. Now let's talk about practical management summary. So if you are in clinic, step 1, identify the phenotype. Young athlete, no risk factors, exertional pattern. Step 2, document pulses and resting ABI. Step 3, if symptoms are convincing but resting tests are normal, do exercise testing and post-exercise ABIs. Step 4, choose targeted imaging and dynamic tests, especially for PAES, which is popliteal artery entrapment syndrome. Step 5, treat the mechanism, decompression of PAES, cyst wall removal or bypass strategy for CAD, which is cystic adventitial disease, anatomy-driven planning for persistent sciatic artery, and avoid quick fix endovascular treatment for external iliac endofibrosis. And if you are on call and you get acute ischemia in young athletic limb with popliteal thrombosis, your safe sequence is thrombolysis may be used to clean runoff, but definitive management still require operative repair of the popliteal artery. Now let's do a quick comparison summary between these rare causes. Okay, this is really useful way to separate the big 4 non-atherosclerotic causes of lower limb ischemia in the exam. Popliteal artery entrapment syndrome is a problem of dynamic external compression, usually in young athlete males. Symptoms are exertional, pulses may be normal, at rest, and classically disappear with active plantar flexion. The pathology progresses from compression to fibrosis, stenosis, or even aneurysm. The treatment is surgical decompression and there is no role for angioplasty or stenting. Next, cystic adventitial disease is completely different. It's an intrinsic arterial wall problem caused by mucin-filled cysts in the adventitia, most often affecting the popliteal artery. Patients are often middle-aged with no risk factors. Imaging shows a focal smooth stenosis. Best treatment is cystic excision with removal of cystic wall or bypass if the wall is degenerative. Persistent sciatic artery. Persistent sciatic artery is a congenital arterial variant. The limb may be supplied by an abnormal persistent vessel often with hypoplastic superficial femoral artery. These patients frequently present with aneurysm embolization and ischemia, and the key important exam findings for these patients are often presence of foot pulses with the absence of femoral pulses. And this is very important to know about this specific entity. Management depends on fully defining the anatomy before intervention. Finally, external iliac artery endofibrosis is seen in endurance athletes, especially cyclists. It's caused by exercise-induced intimal fibrosis, not plaque. Resting ABIs can be normal. Diagnosis requires exercise testing, targeted imaging, and management is surgical correction, not stenting. So the exam takeaway is simple: young patient, no risk factors, exertional symptoms, think mechanism first, artery second. Now let's talk about the management summary. Suspect rare cause in young patient or athletic claudicant or convincing symptoms with palpable pulses, normal resting ABI, do exercise testing plus post-exercise ABI. For popliteal artery entrapment syndrome, dynamic exam, pulse reduction with plantar flexion, dynamic duplex arteriography, CT or MR to delineate the anatomy, and the management is surgical division of medial head of gastrocnemius plus minus arterial reconstruction. No role for angioplasty or stenting. Thrombolysis may clear runoff in acute thrombosis, but definitive operative repair needed. Functional popliteal artery entrapment syndrome treat only if symptomatic. Asymptomatic functional compression may be physiological. Cystic adventitial disease, best results with cystic evacuation plus cyst wall removal if it is short segments. If wall degenerate, resection plus bypass. Avoid patch after extensive cyst work due to early failure. Persistent sciatic artery, image full arterial anatomy and treat complications, often symptomatic with anatomy-driven plan. Okay, now this is the time we will go for rapid-fire questions for our exam preparation. Are you ready? Okay, let's go for it then. Young athletic patient, exertional calf pain, normal pulse at rest, what bedside maneuver suggests popliteal artery entrapment, force plantar flexion, and that cause pulse loss. So this is the dynamic compression which unmarks the entrapment. Next question. Which investigation document flow reduction during provocation in suspected popliteal entrapment? That's duplex ultrasound with provocation, and that demonstrates dynamic arterial compression. What proportion of popliteal entrapment cases are functional rather than anatomical? About 25%. So that's very important to know. That's 1/4 of the popliteal entrapment syndrome are functional. Next, approximately what percentage of popliteal entrapment patients present with acute ischemia? About 10%. So this is important for you to know as well, that the popliteal entrapment can present as acute limb ischemia, but this is only 10%. Next question. What imaging modalities are typically used to confirm popliteal entrapment? Duplex plus MRA or angiography with provocation. This is very important to mention with provocative maneuver. Next question. Best definitive treatment for symptomatic popliteal entrapment. This is surgical decompression, and we know endovascular has no role here. Next, cystic adventitial disease. What is the preferred treatment for short segment lesion? Short segment lesion, we already said, cyst evacuation with removal of cyst wall. Simple aspiration has high recurrence, so do not choose the option of simple aspiration, even though it's mentioned short segment, okay? Next question. Why is patch angioplasty discouraged after extensive cyst removal? Because of high early failure rates and poor durability with patching alone. Next, when is bypass preferred in cystic adventitial disease? When the arterial wall is extensively degenerated. That time you have to choose bypass. Next, what is the prevalence of persistent sciatic artery? Well, about 0.01%, so it's really rare. Next, classic examination finding in persistent sciatic artery, which you already mentioned, absent femoral pulse with preserved distal pulses. And that's when you say it's persistent sciatic artery because limb is supplied by the sciatic artery, not the femoral artery. Next, what proportion of persistent sciatic arteries become aneurysmal? Nearly 50%, and that's the high aneurysm and embolic risk in this situation. Next, key management warning before embolizing a gluteal aneurysm. Exclude persistent sciatic artery first. Embolization may cause limb-threatening ischemia because that is the main arterial supply of that limb. Next, enhanced cyclist with thigh pain only on exertion. Likely diagnosis, we know, is external iliac artery endofibrosis and exercise-induced intimal fibrosis without atherosclerosis. That's the pathology. Now, there are few things that I need to mention as well before we go to the oral and clinical scenarios. For the cystic adventitial disease, this is very important to know that pedal pulses sometimes disappear on knee flexion, and this is called Ishikawa's sign, and this is really very important for you to remember. What is Ishikawa's signs? This is disappearance of pedal pulses on knee flexion. Now, the other important finding for you to remember, if you do angiography, this may show an unusually smooth hourglass stenosis, which is referred as scimitar sign, and this is diagnostic for cystic adventitial disease. So hourglass stenosis or scimitar sign is diagnostic of what? Is diagnostic of cystic adventitial disease. Okay, these are a few things that you need to remember for the exam as well, alongside what has already been mentioned so far. Very good. Let's crack on now to the scenarios. Okay, now as mentioned, let's practice clinical and oral scenario. A 22-year-old competitive runner with exertional calf pain which resolves completely with rest. Examination shows normal pulses at rest, but during forced plantar flexion, the pedal pulses disappears and the pain is reproduced. This pattern strongly suggests a popliteal artery entrapment syndrome. So how would you proceed? I would proceed with duplex ultrasound with provocative maneuvers followed by MR angiography with provocation. Imaging confirms dynamic compression of the popliteal artery without fixed stenosis. Given that patient is symptomatic, the definitive management is surgical decompression of the popliteal artery. There is no role for angioplasty or stenting because the pathology is external compression, not the intrinsic arterial disease. This approach is clearly safe, and failure to decompress leads to progression to thrombosis or aneurysmal degeneration. Postoperatively, the prognosis is excellent if treated early. Thank you very much. We are at the end of this episode. Thanks for listening to Proximal Control Vascular Surgery Exam Prep. If you have found this useful, stay tuned because in the next episode we will discuss upper limb pathologies, tied back to guidelines, evidence, and practice scenarios. Keep listening to Proximal Control. As always, with your support, we will keep growing together in vascular surgery. Because in vascular surgery, control is everything.